Broad first rib posterior to the clavicle is rarely fractured because of its protected position. When fractured, however, injury to the brachial plexus of the nerves and subclavian vessels may occur. Most commonly fractured ribs are the middle ribs, blows or from outflow from the crushing injuries. The weakest part of the rib is just anterior to its angle. Direct violence may fracture a rib anywhere. Its broken end may injure internal organs such as the lung or the spleen. Lower rib fractures may tear the diaphragm and result in a diaphragmatic hernia. Rib fractures are painful because the broken parts move during respiration, coughing, laughing, and sneezing. What is flail chest? In flail chest, there are multiple rib fractures. Sizable segment of the anterior or lateral thoracic wall moves freely. There is paradoxical movement inward on inspiration and outward on expiration. In flail chest, that is a stuff in chest, extremely painful injury and impairs ventilation and affects the blood oxygenation. Treatment of the flail chest involves fixing loose segments with hooks or wires. Thoracotomy, intercostal space incisions, rib incision, and bone grafting. The surgical creation of an opening through thoracic wall to anterior pleural cavity is called a thoracotomy. Surgical procedure. Thoracotomy is done. Anterior thoracotomy technique in which H-shape cuts through the costal cartilages and we will remove the segments. In posterolateral incision, which has been done 5th to 7th intercostal spaces, lateral approach preferred for thoracic cage entry. Patient positioning, laying on the anterolateral side, upper limb fully abducted. Elevation and lateral rotation of the scapula inferior angle. H-shape incision for rib, periosteum and removal. And access to the thoracic cavity for procedures like pneumectomy, rib regeneration after operation, although imperfectly. DPC is sometimes used for autogenous bone grafting in other surgeries. Supernumerary ribs. Typically, humans have 12 ribs on each side, 24 in total. Variation in the rib may occur. Supernumerary ribs, additional ribs beyond the typical 13 pairs, 12 pairs. Cervical ribs more common, 0.5 to 2% prevalence. Lumbar ribs less common, and clinical significance. The cervical rib may interfere with neurovascular structures at the superior thoracic aperture, may contribute to the thoracic outlet syndrome. Extra ribs can complicate the identification of the vertebral levels in radiographs and diagnostic imaging. Protective functioning of the costal cartilages. Provide resilience to the thoracic cage and prevent fracture of the sternum and the ribs from many blows. Remarkable elasticity of the ribs and costal cartilages in the children. Chest compression can cause thoracic injury without a rib fracture. There are changes in the costal cartilages with aging, loss of elasticity in elderly individuals, and there is increased brittleness. Calcification may occur, rendering them radio-opaque in radiographs. Sternal fractures, not common despite subcutaneous location, and occurs in crush injuries such as in car accident, Installation of the airbags has reduced tunnel fractures, typically comminuted fractures. Tunnel breaks into several pieces. Bone fragment displacement uncommon due to deep fascia and pectoralis major attachments. Common site of the fracture is at the sternal angle, especially in elderly people. Sternal injuries and concerns. Primary concern is the risk of heart, myocardial contusion, cardiac rupture, cord tamponade, or pulmonary injury. Mortality associated with the sternal fractures reported as 25 to 45% due to the underlying injuries. Evaluation for underlying visceral injury recommended for all patients with the sternal contusions. In median sternotomy, it is used to assess the thoracic cavity for surgical operations in the mediastinum, sternum divided in the median plane and retracted. Ribs and costal cartilage's flexibility enables the sternal halves to be spread apart, provides good exposure for lung tumor removal, and halves of the sternum joined after surgery, often with the wire sutures. In sternal biopsy, sternal body commonly used for bone marrow needle biopsy pierces the thin cortical bone and enters the vascular trabecular cancellous bone used for obtaining marrow specimen for transplantation, detecting metastatic cancer and the blood discrepancies. Sternal anomalies. Cartilaginous halves of the fetal sternum may not fuse due to defective ossification. Complete sternal cleft is uncommon and can be repaired during infancy. Sternal foramen may exist due to incomplete fusion, not clinically significant but should be recognized in the medical imaging. Perforation of the xiphoid process in elderly, not clinically significant. Protruding xiphoid process in infants usually does not require correction. What is thoracic outlet syndrome? Superior thoracic aperture, often referred to as the thoracic inlet by anatomists. Thoracic inlet is a point of entry for different structures. Clinicians use the term thoracic outlet when emphasizing the arteries and T1 spinal nerves that emerge from the thorax through the aperture. Thoracic outlet syndrome encompasses various conditions in which the emerging structures are affected due to the obstruction of the superior thoracic aperture. Despite the term thoracic, the obstruction causing thoracic outlet syndrome actually occurs outside the aperture in the next roots. Manifestations of the thoracic outlet syndrome primarily involve the upper limb, rib dislocation, slipping, rib syndrome. Displacement of the costal cartilage from the sternum involves the dislocation of the sternocostal cartilage or the displacement of the intercostal joints, common in the body contact spot. Complication may result from the pressure or the damage nearby nerves, vessels, and muscles. Unilateral displacement of the interchondral joints often involves ribs 8, 9, and 10. Trauma causing dislocation can injure underlying structures like the diaphragm and the liver, results in severe pain, especially during deep inspiratory movement, produces a lump-like deformity at the site of displacement. Rib separation, costochondral junction dislocation, refers to the dislocation of the costochondral junction between the rib and its costal cartilage. Typically involves ribs 8 to 10. Tearing of the perichondrium and the periosteum usually occurs. Ribs may move spirally, overriding the rib above and results in the pain. Paralysis of the diaphragm. Paralysis of one half. Hemidiaphragm due to the phrenic nerve injury does not affect the other half. Each diaphragmatic dome has its separate nerve supply. Paralysis causes paradoxical movements. During inspiration, the paradoxical dome ascends. During active contralateral dome compresses abdominal viscera, causing ascent of the paralyzed dome. During expiration, the paralyzed dome descends in response to the lung pressure. Extraperitoneal intrathoracic surgical access. In surgery, endothoracic fascia has a relatively loose nature. It forms a natural cleavage plane, facilitating separating of the costal parietal pleura, lining the lung cavity from the thoracic wall. This separation enables intrathoracic access to extrapleural structures such as lymph nodes. It allows for instrument placement without opening the pleural cavity, thus avoiding potential contamination of the space surrounding the lungs. Dyspnea. Dyspnea is difficult or labored breathing. Individuals with respiratory issues like asthma or heart failure may use respiratory muscle to aid in thoracic cavity expansion. They may lean on their knees or armchairs to stabilize their pectoral girdle. This stabilization allows this muscle to work on the rib attachment and expand the thorax, making breathing easier. Herpes zoster infection leads to shingles, a dermatologically distributed skin lesion. It is reactivated of the varicella zoster virus, which causes chickenpox. The virus primarily affects the spinal ganglia. Symptoms include sharp burning pain in the dermatome supplied by the affected nerve. The affected skin area becomes red with vesicular eruptions. Pain may occur before or after the skin eruptions. This is the diagram of showing the herpes zoster infection. While primarily a sensory neuropathy, about 0.5 to 5% of individuals may experience weakness due to the motor involvement. Weakness typically occurs in the same myotomal distribution as the pain and the vesicular eruptions often observed in elderly cancer patients. Intercostal nerve block. Intercostal nerve block is a procedure for producing local anesthesia in an intercostal space. It involves injecting a local anesthetic agent around the intercostal nerve. The injection is administered between the paravertebral line and the area requiring anesthesia. This procedure targets the intercostal nerve trunk and its collateral branches. The term block indicates that it interrupts the nerve endings in the skin and the transmission of the pain-related impulses through sensory nerves. Sensation loss is prevented from reaching the spinal cord and brain. Since skin typically receives innervation from two adjacent nerves, there is often overlapping of the contiguous dermatomes. Complete loss of sensation usually requires the anesthetization of the two or more intercostal nerves. Pneumothorax, hydrothorax, hemothorax. Pneumothorax entry of the air into the pleural cavity and often used to penetrating the wound in the parietal pleura, for example from the bullet or rupture of the pulmonary lesion into the pleural cavity, bronchopulmonary fistulas. Pneumothorax leads to the lung collapse. Fractured rib can cause and also tear the visceral pleura and lung, causing pneumothorax. Hydrothorax, accumulation of the significant amount of the fluid in the pleural cavity, often resulting from the pleural effusion. Hemothorax, blood entering the pleural cavity, typically occurring with a chest wound. Hemothorax more commonly results from the injury to the major intercostal or internal thoracic vessels than from the lung laceration. If both air and the fluid, pneumothorax, if the fluid in the blood accumulates in the pleural cavity, a radiograph will show an air fluid level or interface indicated by a sharp horizontal line regardless of the patient's position marking the upper surface of the fluid. Hemothorax in the right lung cavity. Thoracentesis is a procedure involving the insertion of the hypodermic needle through an intercostal space into the pleural cavity. It is performed to obtain a sample of the fluid or to remove the substance like blood or pus. To prevent damage to the intercostal nerve and vessels, the needle is inserted above the rib, avoiding collateral branches. The needle passes through the intercostal muscles and the intercostal parietal pleura before reaching the pleural cavity. In thoracentesis, when the patient is upright, interpleural fluid accumulates in the costodiaphragmatic recess. To avoid the inferior border of the lung, needle is typically inserted into the ninth intercostal space in the mid-axillary line during expiration. The needle should be angled upward to prevent penetration of the deep side of the recess, which include a thin layer of diaphragmatic parietal pleura and the diaphragm overlying the liver. Technique for thoracentesis. Insertion of the chest tube. Chest tube are used to remove air, blood, serous fluid, pus, or the combination of these substances from the pleural cavity. The procedure involves making a short incision in the fifth or sixth intercostal space in the mid-axillary line, approximately at the nipple level. The direction of the tube can be adjusted based on the substance to be drained, either superiorly for air removal or inferiorly for fluid drainage. The extraperitoneal end of the tube is connected to an underwater drainage system with controlled suction to prevent air from re-entering the pleural cavity. Removing air allows for re-inflation of a collapsing lung, while failure to remove fluid may lead to the development of the fibrous covering on the lung, inhibiting expansion, lung decortication. Thoracoscopy. Thoracoscopy is a diagnostic and sometimes therapeutic procedure to examine the pleural cavity using a thoracoscope. Small incisions are made into the pleural cavity through an intercostal space. It allows for observation, biopsy collection, and treatment of certain thoracic conditions such as disrupting adhesions or removing plaques. Pleurisy or pleuritis. Pleuritis, also known as pleurisy, is inflammation of the pleura. Inflammation makes the normally smooth and moist pleural surfaces rough. This roughness causes friction, pleural rub, detectable with the stethoscope and sounding like rolling a clump of hair between the fingers. Pleural inflammation may also lead to the adherence of the parietal and visceral layers of the pleural. Acute pleuritis is characterized by a sharp stabbing pain, particularly during exertion such as climbing stairs, when the rate and depth of the respiration may increase slightly. Pleurectomy and pleurodesis. Pleurectomy involves the excision of the part of the pleura often performed during surgery. Obliteration of a pleural cavity due to disease, surgery, or other reasons does not typically lead to the significant functional consequences. However, it may result in pain during exertion. In pleurodesis, adherence of the parietal and the visceral layers of the pleura is induced. This is achieved by covering the opposing layers of the pleura with an irritating powder or sclerosing agent. These procedures, pleurectomy and pleurodesis, are carried out to prevent the recurring spontaneous secondary atelectasis, spontaneous lung collapse. Such atelectasis may occur due to chronic pneumothorax or malignant effusion resulting from the lung disease. Injuries to the cervical pleura and apex of the lung. The cervical pleura and the apex of the lung project through the superior thoracic aperture in the neck posterior to the inferior attachment of the sternocleidomastoid muscle. Wounds. to the base of the neck can result in pneumothorax, which is the presence of the air in the pleural cavity. The cervical pleura is especially vulnerable to injury in infants and young children due to the shortness of their necks. Injury to the other parts of the pleura. The pleura descends below the costal margin in three regions, making them susceptible to the injury during abdominal incisions, the right infrasternal angle and the right and left costovertebral angles. The pleura in the costovertebral angles intromedial to the 12th rib is the posterior to the superior poles of the kidneys. Injuries to these areas may result in pneumothorax when surgical procedures expose the kidney. Pulmonary collapse. Lungs, when distended, are like inflated balloons, but with collapse, if their distension is not maintained due to their inherent elasticity. Secondary atelectasis is the collapse of the previously inflated lung. Primarily, atelectasis refers to the failure of the lung to inflate at birth. Normal lungs remain distended even when the airway is open because of the adherence between the visceral pleura, outer lung surface, and the parietal pleura, inner thoracic wall, caused by the surface tension and pleural fluid between them. The elastic recoil of the lungs results in subatmospheric pressure in the pleural cavity is typically about 2 mm mercury, dropping to about 8 mm mercury during inspiration. Penetrating wounds or holes in the thorax or the lungs cause air to be sucked into the pleural cavity due to negative pressure, breaking the surface tension between the visceral and parietal pleura and causing the lung collapse. The pleural sacs don't normally communicate, thus one lung may be collapsed after surgery, for example without other lung collapsing. Laceration or rupture of the lung surface or penetration of the thoracic wall leads to hemorrhage and the entry of the air into the pleural cavity, with the extent of the pulmonary collapse determined by the amount of the blood and the air accumulation. When the lung collapses, it occupies less volume within the pulmonary cavity. The pulmonary cavity does not increase in size and may even decrease in size during inspiration. Radiographically, the affected lung side of the collapsed lung can be identified by elevation of the diaphragm above the usual level, narrowing of the intercostal spaces, making the ribs closer together, displacement of the mediastinum after often evident through the air-filled trachea within it, shifting towards the affected side. The collapsed lung typically appears denser, whiter, surrounding by more radiolucent blocker, air, or imaging. In open chest surgery, respiration and the lung inflation must be maintained. This is achieved by intubating the trachea with a curved tube. A positive pressure pump is used to alternately inflate and deflate the lung. The pressure is varied to ensure proper lung inflation and ventilation during surgery.